Colon cancer is our third cancer we want to talk about, the number 2 cancer killer on the planet. Jen, talk to us about colon cancer.
Well, the good news is that dying from colon cancer should be pretty uncommon because if you're appropriately risk stratified and you're doing your screening tests, we're going to catch this pretty early, and it's a very slow growing cancer.
Key word there is should.
Should,
but
right.
It's not, which means people aren't being screened.
Yeah.
In English, on a bumper sticker, very few people should be dying from colon cancer, but yet it is the number 2 cancer killer, which means, as a general rule in the population, very few people are being adequately risk stratified and screened.
Yeah.
That's a major problem.
Yeah. I was thinking about this as we were prepping for the podcast, but breast cancer can start in primary care with a mammogram order. Prostate cancer can start in primary care with the PSA test. Colon cancer, you got to see a GI doctor first. So this is a little different, where we loop in a specialist. You know, you have to go get a consult. This is a
to
little
get the colonoscopy.
This is a little bit more cumbersome of a screening process, right?
There's more layers to it.
You have
more
to go
steps.
see a GI doctor. You have to get a consultation. You have to schedule a colonoscopy from there. So anyway, a little bit different there. But traditionally, obviously, the colonoscopy is the screening test, and
it's the gold standard,
right? Used to start at age 50, but now they changed the standards a few years ago to be 45, so they've lowered them.
It's just been a couple years, and I was really proud to hear that they had done that, because you and I had already been beginning to pound that drum just a little bit, especially with folks with risk factors that you'll talk about in a little bit.
Yeah. If it's normal, the good news is you don't have to do it for another 10 years.
Yeah, and I was thinking about this a while back with a patient, and we started doing the math. Like, if you do it at 50 or 45, and you have normal, recommendations now are, by the time you're at 75, if you've never had an abnormal colonoscopy, the recommendation is stop.
Good.
So you're going to get 3 of them if everything's normal.
Right.
So it's not, it feels a lot less like, I have to do these forever. No, not really.
What are the other options other than a colonoscopy?
Well, the gold standard is colonoscopy, because there's nothing like going all the way in through your colon and examining and getting a good idea of what's going on. It speaks to how slow growing colon cancer is, that if it's clear, you can come back in 10 years.
Right.
And even if if a tumor has developed somewhere between the day after your colonoscopy was done and it was clear, it's still going to be not far enough along that identification, resection would not be curative. That's the part that blows my mind. So for a colon cancer to go totally unnoticed, we're talking decades it's been in there.
Yeah.
Just get screened. But there are some people that colonoscopies, it's either their preference, which I would try to encourage that person to kind of
rethink it.
Just make sure you're giving it enough thought, because the benefits of going 10 years is pretty great. You can do something called a flex sig, which is something a colon doctor would do in the office, and they just use a flexible scope, and they look at the bottom portion of your colon in the office. You don't need any sedation, because that's where the majority of colon cancers are going to happen, or within the reach of the flex sig. But that's 5 years, so you get half the runway there. There are some people that don't tolerate anesthesia. This would be a good idea. There are some people who, for various other reasons, this might be an option. Another option would be what would be coined as a virtual colonoscopy, using some fancy CAT scans and kind of recreating the colon. That's a little newer of a technology, but again, 5 years. And then we've got some stool studies where we're looking for either DNA of cancer cells or of blood that would indicate. And these have been shown to be just as effective, but there's a big asterisk on these things, and that is you have to do them every year.
I did not realize that.
If you don't do them every year, because of the nature of you're not looking inside, by the time a cancer is visualized, there's one timeline. By the time that cancer has been around long enough that it's angry and bleeding and kicking off DNA cells is another timeline. By the time that thing is bleeding, It's pretty far along.
Yeah. And this, as you explained to me, this technology is not looking at actual polyps, not looking at your actual tissue.
No. I mean, one of the benefits of a colonoscopy, of going inside and visualizing everything, is while they're in there, they'll snag off all the polyps that they see. All cancers originate from polyps, but not all polyps turn into cancer. And so if you've got some polyps in there, the GI doc will snip those off, send those off to pathology just to make sure. But because you had them, he'll only give you a 5-year runway on the colonoscopy. You'll have to do another one. And so by doing these annual, like it's an acceptable alternative, but you have to do it annually. But you also have to realize that you have no optics at all on what's going on in there in terms of precancer on the horizon. You're totally blind. So like of all of these, I have used the Cologuard in some patients from time to time who are just anti-anesthesia, we're just not doing it. But I never love it. Like I'm never excited about that plan.
Yeah.
Mostly because I feel like every year we have to hope everything's okay. And it's a huge blind spot. Whereas whatever's in there is in there. I'd like to see it. And that's why the colonoscopy is the gold standard.
Yeah. And the Cologuard you could get from your primary care physician.
Absolutely.
You don't necessarily have to go to you would not go to a GI doctor for that.
No, you would not. You could do the Cologuard. Oftentimes where it's a good mechanism, I've seen it applied, like for my own practice, patients who move here and it's time for their colonoscopy, but they're still considering who they want to use, where they want to have it done, where they're going to be for travel, for work, etc. The Cologuard is a wonderful bridge for a 1, 2, 3 year until because life sometimes happens, and then like setting up a whole, like the prep, and then the half a day of having it done, it can be very disruptive, especially for a lot of our folks who are running companies, they're running families. It's very disruptive. And so this is a nice tool in the tool belt, but it's not it's not the ideal thing, but I'm grateful to have it from time to time. Some known risk factors for colon cancer outside of just being a human. Western diet. Clearly, we know that highly processed, low fiber, low nutrient density foods have a tremendous risk profile associated with downstream inflammatory processes, smoking, obesity, inflammatory bowel disease like Crohn's or ulcerative colitis, any type of chronic inflammatory thing. You're putting yourself at risk for overexposure to chronic inflammation, which can flip cancerous in the right person. And then actually alcohol, overindulgence of alcohol.